Hey, and welcome to UroNurse. We meet every Saturday at 9 a.m. Central Time. Glad to see everybody showing up here today for this great talk. If you're watching us on YouTube, great. Be sure to hit that subscribe button and that like button. If this is your first time visiting us, be sure to visit our website at uronurse.com, where you can find out more about us and how to join and be a part of the program. Also, this is your opportunity to look back at all of our old programs. We've got those all listed, starting at the most recent one, going back for last year's programs and everything going forward. So it's your shop spot to catch up with us. We have a really great program for you today. And that program, we're going to follow our typical format that we're going to take general questions. Feel free to use the Q&A box to have any questions that you might think of. So we'll go ahead and look at those first, and then we'll follow that up with our shared stories. And then we're going to get into our main talk today. Again, that talk is going to be given by Paula Wagner. Paula was a attendee not too long ago, and she's going to be talking on pediatric urology. So there's a subject that we have not covered. I'm really anxious to hear more about the wonderful world of kids. So we're going to get ready to get into our favorite stories here just in a moment. Before we do that, I did get a question that came in from Janine Foster, or at least a comment. It says, I'm a registered nurse. I work for the VA. I'm licensed in New York, but I've transferred to North Carolina and have multi-state license as well. So there you have it. We do have some nurses that are working with multiple licenses in different states. I think it's not that hard of a issue to get somebody to get licensed in another state. I know Indiana, you have to just kind of fill out some forms. It's not like you have to take the boards again.
Well, to get licensed as a nurse practitioner, it's a lot of hours and money, and it is a pretty lengthy process.
Okay.
So maybe not as an RN, but as a nurse practitioner.
Yeah, gotcha. So let's get to announcing talking about our, before we get our program going, let's introduce all of our attendees that we have today. We've got 4 great panelists. Paula, why don't you go first since you're new to the group?
Hi, I'm Paula. I like to be called PJ. I'm a nurse practitioner. I see adults part-time and children part-time. And I've been a nurse practitioner for about 25 years, and I'm still in the same university job, although I do cover Shriners Hospital for children, and I'm at a university hospital. And I'm going to talk today about pediatric urology.
Great. And I think most of you know who I am, Vic Sinise. I'm the founder and producer and host for UroNurse. And I've been a urology nurse my whole career too. So, and Andrea, why don't you go ahead and introduce yourself?
My name's Andrea Strong. I'm now a nurse practitioner in a urology clinic. I mainly work with adults, and I have about a decade of experience as a nurse. I did inpatient urology, outpatient float pool. So I'm happy to be here today.
Great. And Lori?
Good morning, everyone. My name is Lori Atkinson. I'm a certified urology registered nurse. I've been a urology nurse for 24 years. I currently work for Northwestern in Geneva, Illinois, and I'm glad to be here as well.
Great. That's what makes this program so successful, that we have all these great panelists to kind of bounce things over and talk about things. So again, feel free to use that Q&A box anytime you have a question. And as we get into our talk with Paula, we're going to go ahead and take any questions that you might have for her. And so you can fill those out at any time. But we're going to start off with a little bit of a shared story. I'm going to kick it off with a pediatric story. So I did a little bit of pediatric urology when we first started. We had a pediatric urologist join our group early on. And so I had gotten the lucky straw to work with him. And so I got to work with him for a year. Now, I got to tell you, God bless you, those folks out there that like to do pediatrics. It's not me. I don't like to work with sick kids, love kids, but not sick ones. But anyway, I did learn a lot about it. But one of the big lessons I'm going to teach you is that when you're taking care of kids, you're taking care of a family. And I found this out as the doctor was explaining a scrotal procedure that was going to be done to this couple's son. And he's talking about it. And our rooms are set up where we have each room, we're lucky enough to have a bathroom attached to it. So works really nice if you're a urology practice to have each one with its own bathroom. And when the doctor's going through it, he's pointing on the scrotum, this is where the cut's going to be. And the father gets up and he goes in the bathroom. Well, never thought anything of it, right? He probably just had to go to the bathroom. Mom's still there listening to the doctor. All of a sudden, boom, this noise. The guy hit the wall. He had a vasovagal response to this description of the procedure. Now, fortunately, he wasn't injured and but he did pass out. It was kind of a scary moment, but I learned a lesson. You got to really, pay attention to the family members as well as to the kids. The kids were the easier part. It's these parents who panic over this stuff. So that's my pediatric big experience story. Lori, you had a story for us today, right?
I do, although I definitely don't do pediatrics either, and I don't choose to. I have 5 kids, and that's enough pediatric for me. I'm done with it. So my story actually happened yesterday. We had a patient who had a prostatectomy. And of course, as urology people, we know that you're not supposed to take out a catheter after a prostatectomy. But the patient ended up going to the emergency room, and lo and behold, they take the catheter out. But when they put the catheter back in, they blew up the balloon in the urethra. Nightmare. It was awful. So of course, this patient, we had a lot of concern for him. The doctor had a lot of concern for us. So obviously he told him, call anytime if you're having a problem. So yesterday he called in the morning, the wife called and said, oh my gosh, she's got all this blood in the urine and it's squirting out the sides of the catheter and so forth. And so we had the patient come in just for an evaluation, and my other nurse is a little bit newer and he's like, maybe he should see the doctor. I said, well, we can, kind of figure it out. And I let the doctor, I know what was going on. And of course, first thing he said is, don't take out the catheter. I know, I'm not taking out the catheter. So the guy comes in, his bag is completely empty. But I said, did you just drain it? And they said, yes, they just drained it. Okay. Well, I could see a little bit of yellow, clear urine coming out of the tube. And so the wife's like, oh, no, I've got a picture of it. So she shows me this picture and I'm like, that looks normal. And she goes, oh, it's all bloody. And I go, did he take a little brown pill that starts with a P? Yeah, I took it last night. I said, that medication turns the urine orange. His urine is orange. There's nothing wrong with it. Oh, no. Nobody told us that. And I'm like, yeah, they don't tell you that. And that's unfortunate because they're thinking it's all this blood. And of course, the stuff that was coming out of the sides of the catheter was bladder spasms. So it was all good.
Oh, yeah, that's a good reminder because you do forget sometimes to warn patients about the change in the color of the urine, and that's
and their contacts. People forget about the contacts. I always ask the patients if they wear contacts because it can actually discolor those as well.
Interesting.
Really? Mm-hmm.
Wow.
Mucous membrane.
I have a lot of patients, females with incontinence and males with incontinence. So I always warn them it'll stain any clothing it touches. So don't wear your good pants.
Yeah, we have a lot of the patients, the docs will say, oh yeah, tell them to go pick up some Peridium or some Azo over the counter in the pharmacy just to have on board in case they have bladder spasms. I always tell the patients, I said, listen, save it if you're really uncomfortable because it's going to make your life miserable. I said, it's going to stain everything. Your wife's going to be upset with you. And I says, it may work, but I said, don't use it unless you have to.
Yeah, our exam tables show pyridium. It doesn't even come out of the exam table, even if you wipe it up right away.
Betadine as well. Iodine stains exam tables.
Oh, yeah. We switched over to benzocholium, BZK, because it's clear and doesn't stain everything. And it's as effective as the antiseptic.
Yeah.
Hey,
I've always wondered. Oh, sorry. I always wondered it with betadine. Why after you put it on and you get it on the tissue or whatever, why it turns purple? Does anybody know?
I don't know this, but when I used to work peds oncology, I think it's the aseptic part of it. Like the literature shows betadine really has to dry, which is why when we do a midstream clean catch, it dries for like 10 or 15 minutes. So that's what I suspect. It's sort of like that violet color that you might use to find an ectopic ureter when you cysto someone so that's what I think.
Always wondered.
I think it has to do with oxidation. when it hits the air, probably the oxygen reacts with it. That's a guess, but or college chemistry. What can I tell you? Rebecca said in this comment, I'm out of urology for the time being, and I was talking with my coworkers about kidney stones. Didn't think anything of it because it's standard talk from where I'm from, but apparently not where I am now because the guy in question got uncomfortable very quickly. Whoops. So, yep, if you leave urology, it's a different world. That's why all of us have stayed in urology, because it's the fun place to be.
Yeah, that's why you get a catheter in your prostatic urethra, not your bladder.
Yep.
If you're in the community.
Absolutely. That's why you come to the pros. So I don't see any other questions. We got to think our shared stories out of the way. So Paula, I'm going to let you switch over to your shared screen and take it from here.
So my little thing at the bottom went away that said shared screen. It was there a second ago.
Let me make sure.
My little icon.
It should still be there. Let's see. So you don't have one that says share screen right now?
I do not. I did a minute ago.
You have all the other icons?
No, I have no icons.
Yeah, that's something with your program where it dropped those.
Well, tell me what I should do, Mr. Techno. Because I
So,
don't know.
I would bring your mouse up to the or down to the bottom.
Oh, there it goes. Okay, I'm all over it now.
Yeah. I was just checking. You are a co-host, so you should be able to do it.
Yay.
Perfect.
Okay, I'm going to start my talk. So, just so everybody sort of knows, the things I'm going to talk about itself could be one talk. Like vesicoureteral reflux could be an hour. So this is a talk that I use for pediatricians, and I had to take like 30 slides out, and I have 76. So some of them I'll sort of breeze over just in the nature of time. So I already introduced myself. I work with Eric Kurzrock, who is a fellowship trained pediatric urologist. And it's just he and I at this point. So, and we work pretty well together. So I see kids 2 or 3 days a week. Uh-oh, how do I go forward?
You can hit your, yeah.
So what is ped urology? GU problems, kidney, ureter, bladder, urethra, testicles, ovaries, reproductive tract, genitals, just some of the things we see. We follow kids, especially if they're born with a congenital condition, sometimes into adulthood, but things we follow, congenital abnormalities, hydronephrosis, multicystic dysplastic kidney, ectopic ureter, reflux, megaure, incontinence, undescended testes, hypospadias, intersex, inguinal hernia, just to name a few things that we see. The first thing I'm going to talk about is vesicoureteral reflux. So if you see a child who has had a febrile UTI, we do an ultrasound and a VCUG. So you'll see on this kiddo, they have bilateral grade 5 reflux. So for those of you who don't know, all the contrast dye should stay in the bladder and not go up the upper tracts. Urine is meant to retrograde down and it'll go back the wrong way. And so 20 to 50% of kids present with a UTI. Well, who might not present with UTI? Well, we know that pregnant moms get their first ultrasound usually between 16 and 18 weeks. You can see the kidney pretty well. So we see lots of kids born with hydronephrosis that get put on prophylactic antibiotics and then get a VCUG. So they really have never had a UTI. So that's the other percentage of kids who've never had an infection that actually have had reflux. Males tend to have worse reflux that gets better faster. And we don't always need to fix it. A lot of kids will outgrow reflux. Here we're giving you some statistics about ethnicity, things to consider: secondary reflux, kids with neurogenic bladder, valves, exstrophy, dysfunctional voiding. So these are kids who we don't often fix their reflux because it's usually a sort of different mechanism. And there's 2 thoughts about why kids have reflux. One is that this tunnel where the ureter tunnels in the trigone of the bladder is not long enough. And the second thought is because it's not long enough, the mucosal behind it is quite weak. And then here we're talking about the prenatal hydronephrosis. You can see this is a kidney turned sideways, and the black fluid is actually urine. And so if you see a kiddo born with hydronephrosis, also it buys you a VCUG. Here, this is demonstrating reflux just on one side. You can have reflux on one side, you can have it on both. There's a universal grading system, 1 to 5. Usually by the time you get to 1, you're sort of done because 1 just urine retrogrades up the ureter and not to the kidney. And you sort of see the degree with looking at the VCUG. You can look at it with the family. Things we rule out, you know, we ask everybody about voiding, about their bowel history. We might do a nuclear scan. We might do an IVP. We look at their blood pressure. There is a grade, you know, what most parents want to know is, okay, my kid has reflux. What are the chances they'll outgrow it? If you guys go to deflux.com, they have a really good graph that shows what age your child was diagnosed, what grade of reflux they have, and in general, when we might expect them to outgrow it. So again, this is a graph of a little different nature. So how do we treat kids who've had reflux? Well, the goal is to prevent urinary tract infections and to prevent febrile UTIs that can cause scars on the kidney. So we use a couple of medicines for prophylaxis. We start kids out on amoxicillin. Once they reach at 2 months of age, their liver has matured, we change them to Bactrim. I use a lot of nitrofurantoin. I like Keflex, but the pharmacy will just fill Keflex 2 weeks at a time. And so it can be problematic in terms of compliance. An ultrasound and VCUG. Indications for surgery, scarring. Despite being on the prophylactic antibiotic, the child gets several infections, medical non-compliance if we're worried about a child maybe in the foster care system about changing multiple homes and they have high-grade reflux. We might think about correcting it. There's 2 ways to correct it surgically. There's intravesical and extravesical, so both just surgical techniques. So they just showed a brief video. There's something called a sting procedure that is a non-surgical way to correct reflux, where a small pediatric scope is put in the urethra, and then you can see the ureters. And the substance is 2 naturally occurring sugars. And so right at where the ureter meets the bladder, the substance is injected. And it's been around for about 20 years, but it's best for low-grade reflux. And a kid cannot have an ectopic ureter or a duplicated system because it just traditionally doesn't work. Sometimes we put a little bit of deflux in a urinary diversion that maybe is leaking. But deflux is a non-surgical option to treat reflux. Prenatal hydronephrosis. As we know, we don't get radiation anymore with ultrasounds. Lots and lots of pregnant women have ultrasounds. So we see a lot of pregnant moms that come that say, my baby has hydronephrosis. What does that mean? We also grade hydronephrosis depending on the degree of the fluid in the ureter. So, you know, here we have the parenchyma where the urine's made, and then we have the drain and the calyces of the kidney. This talks about embryology, about GFR and how much urine the baby makes. And this is sort of for when we see pregnant women, and we talk about the risk factor and where they need to deliver and what needs to happen prenatal and postnatal. On this slide, most women have their first ultrasound at 16 to 18 weeks. The kidney can be pretty well seen. On this slide, 18 to 20 weeks, 90% of kidneys can be seen. Generally, if a high-risk GYN is following somebody and the baby has hydro, they have a lot of ultrasounds that they come with. And then, of course, postnatally, we recommend that you just not do an ultrasound the first 24 hours of the baby's life, because often the amount of dilation is under reported, and babies are dehydrated, and often they're not making a lot of urine that first 24 hours, and it'll fool you to think they have a lesser degree of hydronephrosis. This is the grade of hydro. It's 0 to 4. So hopefully, if you're a peds urologist, you have pediatric radiology, and we're using this universal grading system. We look at everything with our own eyes because we see kids from everywhere. We see kids from 8 hours away. So everybody has to bring their own films on a disc, and then we show the parent the films, because you might have a report that says mild to moderate hydronephrosis. Well, you're sort of like looking at the grading system. What does that mean? What's mild to someone might be minimal to someone else. But we always look at films, as you guys probably do. We never look at reports for anything. We look at films. Here we're showing some hydronephrosis. Up in the corner in the left is a little bit of a dilated pelvis, and in the lower right you see a pelvis and some calyces. Here it's just getting worse. You can see less parenchyma. What are some other things we see? We see UPJs where there's an obstruction in the ureter. We see megaureters, reflux, ectopic ureter, ureteroceles, posterior urethral valves, multicystic dysplastic kidney, prune belly, all things that can cause dilation of the kidney. There are at Stanford and San Francisco, and I think we've done one kid at Davis. If you have a baby that you know has a spinal defect or megacystic colon, there are some institutions that are shunting moms, the baby in utero. I think the literature really shows that the outcome is the same, whether the kiddo gets shunted or not, in terms of their bladder. Like it might help in other areas, but in terms of bladder, it doesn't, they're still born with hydronephrosis and a neurogenic bladder. Oh, here it talks a little bit about some of the literature out there. Outcome of data controls does not include fetal early loss. Present outcomes are similar to postnatal experience. And then we're showing a neonate with some hydro, and then 6 weeks later, the right kidney, the left kidney. And then talking about reflux, males, I think I talked about earlier, males usually have a higher grade of reflux. They usually outgrow it sooner. Here's a picture of a UPJ obstruction that can also cause hydronephrosis. And you see where it's narrow just outside the pelvis, where it goes down to the ureter. And it's just not that it's narrow, it doesn't peristalsis well. So the ureter moves urine a lot like the gut. And about 50% of kids who have a UPJ will outgrow it. And so it depends on the amount of hydronephrosis, and is it worse, and their age, and is it making them sick, as to who we fix and who we don't fix. It's rare that we fix a baby. We usually get a couple ultrasounds to see, has it gotten better, has it gotten worse? Ultrasounds, we follow a lot of kids with ultrasounds. We probably would do a MAG3 on a kiddo with a UPJ to see how the kidney drains and works. We know it's going to drain slower because it's dilated and obstructed. But we want to know, is it clinically obstructed? We don't want to lose function watching a kidney. Most are found prenatal ultrasound. So you might see one kidney that's very, very dilated and the other kidney is not. Certainly you would do a VCUG. They could have reflux. They could have a UPJ. UPJ is more common in males. Generally on the left side, they can be bilaterally where they both need to be fixed. We never fix them both at the same time. Talking a little bit about the adynamic segment. So that segment that's narrow just doesn't move urine well. And of course it's narrow. So it's causing dilation of the kidney, and over time you can lose function. The other time you'll see a UPJ is if it's not picked up when babies are young. Maybe the mom didn't have any ultrasounds or had an ultrasound at 16 weeks and they didn't see the kidneys well. We see it in adolescents that go to a movie. Maybe they'll go to a Star Wars movie and see a movie that's really long in duration and have a big slushy. and wake up in the middle of the night with a lot of renal colic pain and pain on their side. And of course, then they get put in a CT scan because we don't know, is it their bowel, is it their ovary? And we find this big pelvis in a symptomatic kid. So that's the other time it presents. Here we're showing an IVP. We still do quite a bit of IVPs in Pediatric Urology. This is a good picture of an IVP of showing this narrow segment right here of the ureter that connects to the pelvis. Here is an IVP with delayed images. Ways we follow them, again, we might do nuclear scans. Nuclear scan is probably the most invasive test we do, involves a Foley, involves an IV. We do give Lasix halfway through. Kids need a general sedation with a pediatric anesthesiologist. So we might do a nuclear scan to determine function. And certainly if it gets better, the hydro, we may never do another scan. Reasons to do surgery: loss of function, increasing in the dilation. If it's clinically obstructed, we don't want to lose function watching a kidney. Here we're talking about the surgery where that segment of the kidney is removed and you can see it sewn back together. Usually when a kid has a UPJ repair, they will have either an internalized stent or an externalized stent, a little drippy stent coming out the flank incision. Older kids, they do often do older kids robotically. So we do older kids robotically, and depending on their girth, but technically, I think it's a very challenging surgery to do it robotically when they're a bit older. This talks about some articles that really support postoperative pain and anesthesia and antibiotics and medicine. Another thing we see a lot in urology is hypospadias. So usually hypospadias is found in the nursery, and it's classic because you see it almost looks like the baby, the little boy, is partially circumcised. They'll have, the foreskin will be detached from the glands, and here you'll see this hooded foreskin, and there, the meatus is actually right here. So you see it when they were embryologically, it wanted to be at the tip, but this is sort of a blind ending pit, and this is where the baby urinates. Whoops. We have a classification of hydronephrosis, and often when you examine a baby, when they present at 2 or 3 months, it's sometimes really hard to tell because sometimes they'll have some webbing at the scrotum, and what you think might be an anterior when it's released is actually a mid shaft. But we have a nice handout on hypospadias, but these are all the places that you can urinate and where the meatus can be on the external anatomy. Generally, occasionally I see adults who come with hypospadias. They've moved here from a different country and it's never been fixed, and they don't have any meatal stenosis, and they have 20 kids. But generally, unless it's very mild, we recommend fixing it, because usually the meatus the child has doesn't grow with them, and a tube is made to bring it up as close to the tip as possible that's safe for meatal stenosis. Here is a glandular hypospadias, a coronal, so the child urinates right here. You can see the meatus wanted to be there, but the child urinates out of this little wink down here. Here's a subcoronal, so just showing you some of the, here's a midshaft hypospadias. Here's a penoscrotal, the child actually urinates down here. There, you can see the hooded foreskin, and here's the glands. Scrotal hypospadias, you can see down in the scrotum there, they urinate here. Often there's something called cord E, and a parent may say, as we know, kids don't have their full testosterone, but usually they'll have tactile erections. I'm cold, I have to urinate. We induce an erection in the OR of every child that has hypospadias, because a lot of kids will have cord E that can be underappreciated. And so every child is given an induced erection to see if they have cord E, because it's repaired during the hypospadias. Something called megameatus, where the meatal opening is wide, or it actually looks like a fish mouth. Often megameatus, we leave it alone, because as we know, anything we do surgically, anything I say that's man-made can have stenosis, can have, can open, can have a fistula. And if you're born with a megameatus, you know, no one is probably going to know. You're certainly going to be uncircumcised, and unless you're marry a urologist. But I suspect this megameatus is being fixed because you can see cosmetically, it probably, when it's spread apart, the glands, it probably is not so appealing cosmetically. Here they're showing a megameatus right here. Here they're showing a good example of a post-op hypo, and you can see this is a post-op where they have a fistula. So the skin is closed, but look, they're urinating right here. Here, as you can see, the suture line and the meatus right there. Here again, bad example, good example. You can see they're urinating here. Here, they're urinating here. And again, oh, wow, this is really a bad example. So you can see here, they maybe have used some skin maybe from the thigh or put a graft on. Here are the testicles. And here is a good example. Again, this child has some stenosis and some discoloration. Here is a kid with a good example. And again, lots of pictures of bad examples, good examples. I will say often with megameatus, I tell parents when the child gets through their post-op period and the swelling all goes away in the months to come, certainly they're circumcised because they use the foreskin. So you really can't leave the foreskin intact with hypospadias. They'll just look like they're circumcised. No one will ever know that they even had hypospadias. This is an example. We have some twins in our practice, and here they are post-op, both hypospadias. So they look really good. You can see, I call this like the turkey gobbler effect. They still have some swelling of the penile foreskin, especially this little guy. That just will get better with time. It almost looks kind of shaggy. And I always say it's a dependent organ. It hangs, just like if you have a scroll injury, you have swelling for a long, long time. But these two little guys look pretty good. I want to say, I think we have triplets in our practice that all three of the babies have had hypospadias. Hypospadias happens in about 1 of 250 to 500 children, runs in families. We think that maybe if you're exposed to progesterone, you have a higher risk. And what that might mean is a mom maybe is on some progesterone suppositories because she's had a lot of miscarriages. But you know, it's repairable, hypospadias. So again, showing us a picture of the twins. Advances in hypospadias, less complications, better magnification. We'll often do 3 injections of testosterone pre-op for severe hypospadias. We do 20 milligrams 1 month apart, with the last injection being a month before the surgery. It depends on when the degree of hypospadias, when we recommend fixing it. We often will see a baby at 2 or 3 months, not because it needs to be fixed, but because parents are often really concerned about hypospadias. Maybe they don't really have any knowledge of hypospadias and they just want a little bit more information. But generally we fix kids before a year. Undescended testes talks about what happens in the embryo. 80% are palpable. They're somewhere along the inguinal canal. 20% are non-palpable. Of those 20%, 25 are absent. The one thing we don't do, we often see kids with undescended testicles come to us with an ultrasound, and an ultrasound really is not helpful. We know kids don't get radiation with an ultrasound, but it's the one thing, really, you can just send kids who have an undescended testicle. They don't need any ultrasounds or any workup. Here's an example that shows all the positions the testicle can be in. So the abdominal ones are the ones you can't feel. These are the one that 20% of the time, they're just not a good testicle, but you still have to go in and prove it. Most of them are inguinal, so all the places that it can be. The important thing to know about an undescended testicle is even if they lose one testes, their fertility is still good, and when they are past puberty, we can put a prostatic testicle in that doesn't have the same risk as like a breast implant if it's bothersome to of course, we teach everyone to do scrotal exams. The risk of cancer is theoretical because we fix them. We know we don't leave one testicle in the abdomen. When one side is fixed, they always put the scope through and they PEXI the other side, because if you're going to be in the scrotum, you'll just PEXI down both of them. Oh, here we go. Diagnosis. A scrotal ultrasound is not indicated. When should you send a patient? If they're non-palpable, 6 months. If they're palpable, 9 months. Sometimes we do a small dose of HCG, but usually they're kids that have mixed genitalia. So we're trying to sort out in the early period, is it an ovary, is it a testicle? Here is laparoscopically looking in and seeing an abdominal testicle and looking at some structures to identify where it might be. Here is, they're taking this out, not atrophic, not a good testicle. So that's what they're showing us here. And here they're showing us there's a population that has a looping vas, which just makes the surgery a little bit more technically difficult. Retractable testicles, sometimes we see kids who are a little bit older. And generally, if they have had good scrotal exams, they're generally, as we say, retractable testicles. And there is some literature that kids who have a female provider have a higher risk of being sent to urologists for an undescended testicle. There's things like, what's the temperature in the room? Is the child nervous? But usually we can examine a kid. I usually examine a kid and put them in a frog position and then make my hands really, really, really warm. So our little test is, even if the scrotum is in the high testicle, if you bring it down to the low testicle and take your hands away and go back, can it be stayed? Will it stay down? And if it's a yes, it doesn't need to be fixed. Hernias and hydroceles, we know that there is a little septum between the inguinal area and the abdominal cavity that closes at birth. If it does not, fluid can move between it. Thus, you can get a hydrocele. Bowel can come down. You can get a hernia. Talks about when to fix them. Generally, if a kid has a hernia, it's usually recognized by family. It's usually a diagnosis that the family will come in. And now cell phones are great. They usually bring pictures. We usually fix a hernia pretty quickly, and just because there's a risk that it can incarcerate. So we just give the family a lot of education. If the child is fussy, if they're constipated, they really need to open the diaper and look. And if it can't be made smaller or reduced, they need to present to an ER. So those are just probably patients that deserve a little phone call that they're sending a kid, and we'll get them in to be seen. I think the wait list for an appointment it's something crazy, like 6 months, and we're booked out a year for surgery. So a lot of phone calls go a long way. Incidents, we see a lot of hernias on premature babies. Ped surgery, there's a little bit of overlap. Ped surgery usually fix babies that are premature. We tend to fix older kids. Here they're talking about the incidence of the right, left, bilateral. We see girls with inguinal hernias. It's of course a little bit rare, but we do see females that have a bulge. If you don't see it in the office, if the parent tells you, I only really see it when the child's really crying or really straining, usually you can make a kid cry or hold their breath or blow in their face. So you can get that Valsalva. Or I tell kids sometimes, pretend you're going underwater and you're holding your breath, and you'll see it get big. Risk factors, prematurity, intersex hypospadias. Sometimes there's an associated undescended testicle. Females, of course, can have hernias. Diagnosis, if you see a bump, and it's usually a parent reported. Complication, you can have incarceration. That's why we give the families a lot of education. If it can't be easily reduced or it's red, they need to get to an emergency room. I could see I probably have about 5 minutes. Risk of incarceration is higher in premature babies. Well, what do we do if a kid comes in with a hernia that can't be retracted. We might give the kiddo a little bit of sedation and put some pressure and try and reduce it, and maybe take them to the OR in the morning and admit them. Risk factors about hernias. I'm going to sort of this. Hernias are usually fixed sooner than later. Here you can see the hemostats are showing they're ligating the actual hernia sac on this baby. Here they're dissecting the hernia sac. Labial adhesions, one of the things we see, it used to be we used to treat every labial adhesion. The urine really manages to find its way out, and it's rare that you need to do a surgery. And you can see this little girl has some absorbable sutures, really rare, just one of the things we see. We often even don't treat it. Sometimes you'll see it on a toilet training kid that's having a little bit of dripping, that posterior, you can see it, it's still fused. We might have them sit backwards on the toilet, double void. Other things we see, neurogenic bladder, multicystic kidney, cloacal abnormalities. Certainly we take care of kids at Shriners. We do lots of diversions, bladder augmentations. We also treat bowel if it's neurogenic in kids. Some of this I'm just going to go through because it just talks about ways to repair things. So we see a ton of things, but I just really tried to focus on the surgical things we see the most. But we certainly see lots of wetting, bedwetting, circumcision, incontinence, lots and lots of pediatric issues. So really, that's sort of my little overview about urology. Does anyone have any questions?
Hey, Paula, why don't you take the screen share off so we can bring
Okay.
up our
Doing
other
that.
panelist.
Okay, there we go.
That was a great
Not one
presentation, by the
question?
way.
Not one question?
Thank you for that presentation, Paula. That was amazing. I see some of your patients in the adult world. So that was very interesting. Can you explain a VCUG for some of the participants who are newer to urology?
Yep. So a VCUG is the one X-ray that you should have a pediatric radiologist, because it does matter. It has to be a complete VCUG with a filling and a voiding. So VCUG does not require any sedation. The pediatric radiology actually does the VCUG. They typically will put a 6 French catheter in a baby and quickly fill the bladder, and you can see reflux during filling. And it's just a diagnostic if you have it during filling that it's harder to outgrow and takes you longer to outgrow. And then when the child, so they fill the child's bladder with cystographin and to a capacity, or when the child starts to void, and they pull the catheter out and take images during the kid urinating. So a VCUG will tell us a couple of things. It'll tell us if you have reflux, and there is something that boys get called posterior urethral valves, where they have a little bit of tissue in the urethra that normally sort of gets absorbed before birth, and it can create an obstruction, and the valves need to be ablated. So the VCUG also shows us really good pictures of the urethra, but it's the one X-ray. The ultrasound doesn't matter, but it's the one diagnostic test that really needs a pediatric radiologist. Peds radiology has a tilt table. So when kids urinate, for bigger kids, they'll tilt them up once they're full so they can urinate. I think they also have child life present, but it doesn't hurt. We all know catheterizing a kid doesn't hurt. Usually it's mostly babies that get VCUG. Even older kids that come over, you'll ask them, how was your VCUG? They're like, no problem. So of course, explaining to them what's going to happen, because they do clean their genitals and put a catheter in. But we get a lot of questions about sedation. Kids do not need to be sedated. Actually, we don't sedate kids because it can alter the effects of a VCUG. It can change when they urinate and the bladder compliance.
That's great. We do have some.
I don't think peds radiology has ever not been able to place a little catheter, a drippy stent, or a small little 6 French cath or a coude cath. So I know we hear that a lot. People will say, I presented an ER and they couldn't get a catheter in, and we know that every child can be catheterized. I mean,
Thank
you. Do you guys use feeding tubes for catheters?
No, we use, usually kids can accommodate an 8 French. We might use a feeding tube on a baby in the NICU, a premature baby, and we do drippy stents. even with hypospadias, we use Folliceal catheters. Are you familiar with Folliceal?
Nope.
Folliceal is great because with hypospadias, when you take the catheter out at the meatus, you'll sometimes have some bleeding, even if you take down the balloon, because when you take down the balloon, how it'll have those rough ridge edges. A Folliceal is a catheter that is smooth. It has a balloon that you blow up, but when you take down the balloon, it's smooth. Folliceal catheters cost a little bit more, but they're also good for a patient who has a suprapubic tract that you're trying to upsize them. We sometimes have interventional radiology put a suprapubic tube in an adult who really is not healthy enough to go to the OR. They might put a 14 French catheter in for a suprapubic. So with time, we upsize the person. So it really helps if they have any stenosis at the skin level to get through that stenosis, and then it lets you upsize them. So we use a lot of Folliceal catheters because it just really helps postoperatively. Does anyone else use Folliceals?
I do have a couple comments that came in from the attendees. Neil Smith stated, excellent presentation, very informative. Thanks, Paula. So thanks for that follow-up. And Rebecca Strickland said, for undescended testicles, is there a timeline for how soon it should be repaired? There was a lot of information for one talk. We should have you come back for more in-depth talk. I agree with that one. It'd be great to have you come back and do a deep dive on some of these subjects.
Yeah. Well, I think what even works better is people just asking questions, because if most people see adults and are just sort of kind of want to know the basics or have some questions like what's the AAP stance on getting a urine or reflux, or because it's just hard to know what people's experience. Like a lot of people maybe never will see a kid. So undescended testicle, we like to fix undescended testicle between 6 to 9 months. We do see older kids that come in with a non-palp test or a testicle that's in the inguinal canal, that they're quite tall and older. So they might have a 2-stage repair. The first stage repair, you might bring the testicle with some collateral circulation down in the inguinal area, and the second stage, come back 6 months later and bring it in the scrotum. We've also placed the testicle, you guys have probably seen this, for kids who are going to have radiation in the pelvic area. We've also put the testicles in the inguinal folds in the thigh, and then later taken them out of the thigh and put them back in the scrotum for anybody who's going to be radiated in the pelvic area. But I mean, there's just so many things we do in pediatric urology. We've taken a tube from a tube that really on one side and used it to create a catheterizable channel. We've taken a fallopian tube. So we do all kinds of things to improve people's quality of life. And, we just do so much in pediatric. It's hard to even, know what to talk about because it's so much.
Yeah, one of the thoughts I had was I was listening through this because it brought back a lot of memories. But for those nurses that are out there considering certification, a lot of this was a great review of what you need to know for the test, for the certification, the pediatric side. So I thought it was a great presentation on, again, a lot of information. I know that a lot of the stuff we could take a deep dive on is in the future. I'm glad to always welcome that. Yeah. Again, if you have any questions for Paula, this is your chance to go ahead and submit those. I think
the important thing is, if you have a child who needs a surgery, I think having surgery at a university hospital, there are a lot of adult urologists who on their business card will say pediatric, but they're not fellowship trained. They haven't done a fellowship. And so if it was my kid, I really think kids are better cared for at a hospital where they have pediatric anesthesia. And if you have a kid with bladder exstrophy or Vater syndrome, we do combined clinics with peds nephrology, with endocrinology. We have a neuropsychologist part of our team. And so it really requires a whole team of people to do pediatric.
Yeah, it's a good point. John Lynn said it 100% agrees. John Lynn is a general practice urologist out of Arizona. And I have to say, you're dead on. Go to a place that has pediatrics, period, because as you said, you're looking at pediatric anesthesiology, pediatric radiology, and pediatric surgeon. Those are specialties that are designed to handle kids.
Yeah. But I think kids are easy. I mean, I see adults 2 days a week. I would 100% rather see kids than adults, 100%.
And I'm glad you do. I remember giving those testosterone injections for the undescended
Hypospadia.
testicles
Yeah.
and for hypospadias to help build up. And that was a question I was going to have. I seem to recall something. When you see somebody with hypospadias, those are the patients that they normally recommend don't get circumcised, correct?
Right. Yeah, exactly. Because we use the foreskin. Now that brings up a good point. What often will happen, we have a lot of pediatricians who call us and say, I'm doing a circumcision and the kid has a funny meatus. And we say, send us a picture. And they have a mega meatus. And we say, go ahead and finish the circumcision because that kid is never going to ever need to be repaired. But not that you can't. The other thing I really didn't talk about is we also do free grafts from the inside of the mouth in Pediatric Urology. And so let's say a kid was circumcised. They come to you from somewhere else and they're circumcised. Or let's say they've had a hypospadias repair 5 years ago and now they have a fistula. Well, we use lots of free grafts from the inside of the mouth, but usually kids aren't circumcised because they look circumcised when they're born. So usually it's pretty clear that they have hypospadias.
Yeah, good point. I had a question as far as X-ray goes. I know that there was a study out that I'm aware of about the use of X-ray, and especially in younger people, that down the line there's an increased risk of different cancers showing up. And I'm assuming that's why you choose IVP over CT scan because of less radiation. Yeah,
and we peds radiology. We also have an interventional radiologist who does low dose radiation. And so, so we do a lot of IVPs. It's rare. We see kids that come to us with CTs. If you were going to do a CT, you would probably do a CT urogram versus a plain a CT with dye if you had your druthers. But a lot of kids who have abdominal pain or who present with a UPJ during adolescence will present to emergency room and get a CT scan because they don't know, is it torsion of your ovary? Is it appendicitis? And probably if you see an older kid with belly pain, probably the provider in the emergency room isn't necessarily thinking urological stuff. I mean, we would be, but they might go, oh gosh, I didn't expect to find this. I have big dilated kidney or
would your follow-up be more ultrasound versus X-ray after surgery or?
Yeah, yes. It's even rare if a kid is fixed. If a kid is fixed for reflux surgically, it's about 99.9% effective. For deflux, depending on the grade of reflux, if you go to their website, it's one of my favorite websites. Sometimes we do deflux twice, or you double sting a patient, depending on the amount of reflux they have. But it's rare that we do a VCUG post-op. Unless they really have febrile infections, we might do one. But yeah, we mostly follow kids with ultrasounds. And it's nice because we show the family every film. You guys probably do that as well. You pull up the film and you say, this is a CT. It cuts you like a bread loaf, and you go through it and show the patient.
Absolutely. Fran Foley sent in a comment for you. I've been grateful for pediatric nurses also. Thank you.
Oh, it's so funny. I don't like adults, but I see adults.
That's why there's all sorts of us out here.
Yeah.
Because you're probably thankful for the adults who have to deal with, or the people who deal with adult patients, and we're thankful for the people who deal with the pediatric patients.
Yeah,
absolutely.
Well, you know what's interesting? I don't think in my whole 25 years I've ever had a problem with a parent. Even I think as long as you really explain things, we draw pictures. If they're inpatient, I say to them, lots of teams come through. Have a piece of notebook paper, have people introduce themselves, write their name down. Don't let people pull your covers off your kid. Who are you? It just seems like it's kind of common sense stuff, but.
Yeah, we were having a discussion. I don't know if it was at after hours or when we did it, but we were talking about the doctors who like to write on the table paper, draw pictures on table paper.
Yeah. Well, we put it in the chart. We take a picture, you know, you can take a picture from your phone and it's scanned right to the chart. So everybody can see it. You know, I think the biggest thing is people's resistance sometimes to see a nurse practitioner. And this is why I love the pediatric urologist. Like, let's say I see a kid for bedwetting, or, you know, I do all the Paristine teaching. Let's say the parent is adamant about seeing a pediatric urologist. Well, we have clinic next to each other, like, because I'll grab him sometimes for patients, he'll grab me. So he'll go in and say to the patient, oh, your kid is here for bedwetting. I don't know anything about bedwetting. Let me get the NP. She knows everything about bedwetting. And so I also think it's really great. And it also probably happens in the adult service. You might see a prostatectomy for continence, for sexual function. I love that the attending says, no, you're going to see the NP follow-up. The NP knows, or you're going to see the nurse. The nurse does all the teaching. The nurse knows. So I think, you know, having the attending really support you and your expertise and your knowledge is also really helpful.
Yeah, I agree. I think that the collaborative practices can't be beat. It's the best thing for patient care. And I think a strong physician supporting, as you just said, saying, hey, listen, my nurse is that expert. You need to see my nurse. And admitting that they're not the ones that are just going to spend the time with the teaching, et cetera, makes a huge difference. And patients, I think, appreciate it too. I think I've always found, I think patients feel like they can understand what the nurse is saying, but they think they can't understand doctor talk.
Yeah.
So
yeah,
it's
true.
It is a great thing to have. And my last comment before we end is cell phone. What a difference it's made in our practice. The ability of people to take pictures and show us, and sometimes it's like overshow us. You get all these pictures sent to you. I'm sure most of us that are nurses out there and have grandkids are getting pictures for their kids. Hey, Dad, what's this? Hey, Mom, what's this? And you get all these different rashes. For me, it's like the rash of the week with 9 grandkids, but it's made a big difference. I think it's a positive difference too.
Yeah. On the adult side, I always ask the adult for permission because, you know, it's scanned under their media mail. So whether they show up in the ED or GI, well, they might put a big picture up of their labia. And, you know, if it's medical people, we're looking for a reason. But a woman who gave me permission later then sent medical records this big note about she wanted it taken out of her chart, and medical records asked me. And I'm like, well, I can't take it out of her chart. It's part of her history. I mean, it was just crazy. But yeah. Yeah.
Oh, great. Really appreciate your talk. And actually that leads to our next thing, which is our next week's talk. We're going to be having Anthony Sam. Anthony Sam is a defense attorney for malpractice. So he's going to be talking on how we can minimize our risk of malpractice in lawsuits. Definitely the time to come back and have any legal questions that you might ask. Anthony Sam's a great speaker and was real happy to volunteer his time for UroNurse to do this. So we can ask a little bit about those pictures and down the line what the legality of that is. For those of you that can't get enough, again, feel free to hit that red button on uronurse.com. It says after party, because it is a party. So if you want to come back, have any other questions that you want to talk about or anything, again, as we've covered everything up to including buying a car. So all things are on for the after party.
Buying a car, really?
We did. We got one of our attendees who got advice, and she actually sent me a picture of the car she bought. So yeah, we do everything at the after party. So if you want to hang out and just talk about whatever, it's going to open the after party. Hope to see everybody next week. Janine Foster threw in a comment. Hey, thank you very much. So you got lots of thank yous coming in here. So it was a great presentation. Again, glad to have you on. I would hope maybe we can bring you on in the future again, maybe do a deeper dive into some of these pediatric things in particular. That's really what we try to do with UroNurse, is to take that deep dive into subjects. For those of you that are in the cold climates, enjoy that cold weather and snow. Those of you that are in the West Coast, you finally got your water you wanted, right? And for the rest of you, we'll see you next week for that great talk on the legal problems that you can get into with what we do for a living. Hey, everybody. Thanks, panelists, for showing up. as always. Can't do the show without you. It's been great. And we'll see everybody who wants to see us in the after party. Goodbye for now.
Bye-bye.
Thank you, Paula. Thanks,
You're
everyone.
welcome.